Good afternoon. I was just trying to figure out if I could get the pointer to work, but anyway, my slides don't need a pointer. And I had the rare honor of starting off this conference. I gave the first talk yesterday, and I'm also closing up, and I would like to thank all the delegates who are still remaining here. So I'll be talking very briefly about the endocrine causes of fatigue. It's something we need to keep in mind. I think that's basically all I can sort of finish or leave you with at the end. Two things regarding endocrine causes of fatigue. Think of it frequently, interpret the test carefully. Those are the two things we need to keep in mind. So if we think about fatigue, it is described as an unpleasant physical, cognitive, or an emotional symptom. A tiredness which is not relieved by our common strategies that restore energy. It can be used to describe either reduced power output or muscular force. So people who have difficulty walking, who do not want to exercise, or the reduced capacity to perform multiple tasks over time, or a subjective experience of feeling exhausted, tired, weak, or having lack of energy, which I think would be sort of 50 to 60% of the patients who come into our clinic daily. It is estimated that 20 to 25% of the so-called normal population suffer from fatigue, and in less than 10%, a physical cause can be identified. There are a lot of papers about fatigue, but just to point out some basic characterization that is used when you study fatigue, it can be classified as recent, prolonged, or chronic. The reason that is important is particularly when you've known your patient for a long period of time, and this is not a person who commonly complains of fatigue, and they come in and they say, I'm feeling tired, doctor, this is not my usual self. Particularly if you have known this person for a long time and you know that this is not a new symptom, I think we have to sort of look further and try and find if there is some other cause for their fatigue. So this is the sort of the time frame for recent, prolonged, and chronic. Or it can be syndromic or idiopathic or isolated. So syndromic comes under the category of this chronic fatigue syndrome, or now what is called myalgic encephalomyelitis. And you can look at the criteria there, but I just wanted to point to the last two things. In addition to their fatigue, which is to the extent of causing them an impairment in their ability to engage with their usual activities, you also need one of these two, orthostatic intolerance and cognitive impairment. This is the current guidelines or what has come up as the guideline statement for diagnosis of chronic fatigue syndrome. This has nothing to do with endocrine causes of fatigue, but to say that the fatigue that patients complain of may belong to this type of a syndrome, or it can be just an isolated feature. There are various ways of assessing fatigue. This is one, for example, a fatigue severity scale, and people fill it out. If you're going to treat someone for fatigue, it may make sense for them to fill out something like this. Quite often what we would find is, obviously we know, as doctors we know, fatigue is related to other things, not sleeping properly, fatigue due to other things in the environment. And quite often, even if after we start treatment, we find that there is absolutely no improvement in the symptoms, I think we have to take a step back and wonder whether our diagnosis was correct to begin with. Coming to the endocrine causes of fatigue, it can happen in diabetes and related causes, and of course all of the other endocrine glands, thyroid, adrenal, parathyroid, hypogonadism, and hypopituitarism. I'm going to spend a little bit more time on diagnosis and hypogonadism in men and adrenal insufficiency, just in terms of interpreting lab reports. So when we look at diabetes and fatigue, it can be due to the disease itself, it can be due to treatment factors, or it can be due to other associated conditions in diabetes. So diabetes and fatigue due to the disease, it can be the first symptom of diabetes. Quite often people come in saying, I'm feeling very tired, doctor, I just did a blood sugar check and it was 300 or 400 or whatever. So fatigue is a very common symptom of diabetes. And it's also associated with glycemic fluctuation. So for example, when people say between breakfast and lunch, I'm feeling tired, it's because of a rapid drop in their blood sugar. So it's a very common complaint when the postprandial blood sugars drop. And if they have a severe hypoglycemic episode, once they have a hypoglycemic episode, the fatigue actually lasts for about 24 hours after that episode. And particularly older people take longer to recover from a hypoglycemic episode. So due to the disease or due to the glycemic fluctuations itself, people may complain of fatigue. Studies have been done looking at the associations of diabetes complications with fatigue, and you can see that in this table, you can see that significant correlation exists between fatigue and diabetic neuropathy, fatigue and cardiovascular disease in people with diabetes or with a history of a CVA. So people who have complications, all the others slightly more. People who have retinopathy, nephropathy tend to have fatigue more commonly, but it did not reach significance in this particular study. But suffice it to say that people who've had diabetes for a long period of time, particularly if they have neuropathy or a history of CVA or cardiovascular disease, are more likely to suffer from fatigue, probably because of the diabetes per se, the underlying disease per se. Due to the treatment, like I mentioned, either if they are on OHAs or insulin causing glycemic fluctuations, they may suffer from fatigue. B12 deficiency is a very common reason in our country for fatigue. If you start reading the B12 literature, you'll think it's like one underdiagnosed, underreported epidemic. In our country, we've always been happy about giving B12 injections, so I think we sort of compensate for the fact that we probably have a high level of B12 deficiency because of predominantly vegetarian population, because we are used to giving the B12 injections. And what I would consider as mental fatigue, someone who has to check their blood sugars 4 times a day, or even say weekly once or weekly twice, frequent injections, 4 injections a day, frequent monitoring, leading to what is called mental fatigue. Sometimes patients just give up, they're tired, they do not want to do it anymore. So that can also be a reason for fatigue, and we need to keep it in mind when we are evaluating fatigue in people with diabetes. Other associated conditions which may be causing fatigue, obstructive sleep apnea is an important thing to keep in mind. Of course, a good night's sleep is one of the main treatment for fatigue, but over and beyond that, obstructive sleep apnea is a very common association, particularly with obese type 2 diabetics. But sleep disordered breathing can also be seen in lean type 1 and type 2 diabetes, particularly associated with neuropathy, and may be a common cause for fatigue. So have you had a good night's sleep? Do you sleep well? Do you wake up refreshed? Is a very good leading question to pick up a cause of fatigue. B12 deficiency I spoke about. Fibromyalgia is more common in people with diabetes, probably related to the hyperinflammatory state. I don't think we've gotten to the bottom of what fibromyalgia is actually caused by, but it is seen more commonly in people with diabetes compared to controls. Depression may be a very common cause for fatigue. We know that diabetes, depression, and dementia is considered one deadly triad. People with diabetes are more commonly depressed, and fatigue may be the first manifestation of depression in people with diabetes. And studies have shown that it all goes together. People who are more depressed tend to have higher HbA1c. Cause and effect, I do not know, but they do go together. Coming to thyroid diseases and fatigue, it's a very common complaint in hypothyroidism. In fact, probably any person who comes in with tiredness or fatigue, one of the first tests a lot of us do is a thyroid profile. And it is estimated that 80 to 90% of people with hypothyroidism will have a complaint of fatigue. And studies have also shown that autoimmune thyroid disease, what Muthu was talking about in the previous lecture, Hashimoto's thyroiditis probably is associated with more fatigue, maybe because of the inflammatory component, as compared to, say, hypothyroidism after a thyroidectomy or so. However, if the symptoms of fatigue do not settle with your thyroid medication within 3 to 6 months, look for alternative or additional diagnosis. This was a good study which was done in Europe. They looked at a middle-aged population, and I just put up this one slide to show that when they took a general population, there was absolutely no difference in TSH levels in people who complained of fatigue versus no fatigue. So in general, the thyroid hypothyroidism, though it is common, is not a common cause for fatigue in the general population. So like I said, we need to keep in mind that it is very uncommon in the general population as a cause for fatigue, and levothyroxine replacement has not been shown to consistently reduce fatigue in studies. And among non-pregnant adults with subclinical hypothyroidism, again, fatigue alone is not a reason for treatment. Again, Muthu mentioned some reasons for treatment, cardiovascular risk, and so on and so forth, positive TPO antibodies, but fatigue alone may not be. At the best, you can think of it as a trial of levothyroxine to see if the symptoms of fatigue improve, but it's not been shown to consistently improve fatigue. Moving on to hyperthyroidism, that can also present as fatigue, particularly this entity of apathetic hyperthyroidism. And this is a very interesting entity in which we need to keep in mind. Among the elderly, only 25 to 30 to 35% will have the typical symptoms of thyrotoxicosis. In this entity called apathetic hyperthyroidism, they're mainly present with lethargy, weakness, apathy, and depression. along with weight loss. So that bit of it looks like the hyperthyroidism. Though the apathy and the listlessness would look like hypo, they are actually hyperthyroid. And the weight loss, which is commonly seen, often leads to a misdiagnosis as a malignancy or a tuberculosis. They tend to be tachycardic, they tend to have high blood sugars, they tend to have high blood pressure. So hypertension, hyperglycemia is common. However, unlike thyrotoxicosis, they tend to, the prevalence of increased heat intolerance or sweating is not there. Typical biochemical features is what you would see: a very suppressed TSH less than 0.01, high T4, T3. However, other things like hand tremors and ophthalmopathy is uncommon, and interestingly in this the skin is dry. Unlike in our typical hyperthyroidism where because they are sweating a lot the skin will be soft, in these older people with apathetic hyperthyroidism in general the skin will be dry. So again a high index of suspicion, anybody who is more depressed than usual for which we cannot find a cause, apathetic hyperthyroidism can be a reason. Management is the same as any other hyperthyroidism. Moving on to hypogonadism and fatigue in men particularly, hypogonadism and fatigue. If you look at less specific symptoms and signs, these are the typical symptoms and signs of hypogonadism in men: reduced sexual libido or less erection, so on and so forth. If you look at the less specific symptoms and signs, you can see decreased energy, motivation, initiative, self-confidence, feeling sad or blue, depressed, so on and so forth, poor concentration, increased sleepiness. So hypogonadism may be a cause for fatigue, particularly among older men. There is something called the Adam Questionnaire, which was published by our endocrine society, which is the androgen deficiency in aging male, Adam Questionnaire, and you can look at the questions which are there. If you have a strong suspicion about whether it is a hypogonadism due to age in male causing the fatigue, you can go through this questionnaire. And they're typical, the reports would be like this. This is a case which was put up by the Endocrine Society in the guidelines that they gave out. For example, a 66-year-old male who presents with reduced libido and osteopenia. And you can look at his total testosterone. Total testosterone is 250 at 8 a.m., 250 on one day and 265 on the next day. And you can see that the normal range is given there, 270 to 890. And the free testosterone is 90 within the normal range. LH and FSH are well within the normal range. So the diagnosis currently of hypogonadism is based upon a low testosterone, low total testosterone level, not a free testosterone, low total testosterone level. So normal total testosterone is estimated between 300 to 1000 nanogram per DL. It tends to fall with age. In general, as we get older, similar to how women have a menopause, male also tend to have a andropause or male menopause it is called, but the levels fall more gradually. In women it is rapid and sudden. Within 6 months you have the estrogen falling. In men it's a very slow decline. So normal total testosterone tends to fall with age. Less than 300 or in some guidelines less than 270 is considered suggestive of hypogonadism. We have to repeat it 2 or 3 times because there is significant day-to-day variation. And only about 1% of that total testosterone is considered the active testosterone. Usually that tends to be in the normal range. So when you have a low total testosterone, certainly if it's below 200, you have the diagnosis. Borderline values where you're not sure, you'll evaluate it further, make sure there is no other reason for hypogonadism. So you would do the usual things, you check their thyroid, you check the prolactin, you check their LH, FSH, consider during pituitary profiling if they have a low testosterone. Sometimes you might have borderline, you might have a value of say 300, but very suggestive symptoms. So let's say you have a 55-year-old man with a testosterone of 300 with a normal LH and FSH with a significant complaint of fatigue. Sometimes we have to go ahead and give a trial of testosterone therapy to see if the symptoms of fatigue improve. And which are the places where you cannot give testosterone, where this should not be done, would be here. If they have a history of prostate cancer, so before considering testosterone replacement as a trial, definitely get a PSA, look at their prostate, or history of breast cancer. Unevaluated prostate nodule, a PSA more than 4, you can look at all the contraindications, or if they have prostatic symptoms, severe lower urinary tract symptoms, or poorly controlled heart failure. So these are all the contraindications to giving testosterone therapy. If they do not have that and you have a doubtful case, so this is the problem with fatigue and endocrine cases. Quite often we may have to do a trial of therapy to see if symptoms improve based on borderline reports. Hyperparathyroidism is a common cause for fatigue. Hyperparathyroidism itself is common in the population, maybe 1 to 5% of population. Most people with hyperparathyroidism and slightly elevated calcium are asymptomatic. However, sometimes they may present with fatigue, irritability, confusion, and studies have clearly shown that after they've undergone the treatment, which is the parathyroidectomy, their symptoms improve within 7 to 10 days. So very clearly there is a correlation between the high PTH and the slightly high calcium and their symptoms, and once they get treated, the symptoms improve. One thing to keep in mind, of course, the way we would screen is doing a calcium, phosphorus, PTH, and a vitamin D. But keep in mind that there is this entity called normocalcemic hyperparathyroidism, where you would have a high normal or a high calcium, but a high PTH, but a normal calcium, and the calcium is normal because of the vitamin D deficiency. So keep in mind this entity when you're screening. Adrenal insufficiency, again, very common cause for fatigue, very rare. It is estimated that only about 100 in a million people will develop primary adrenal insufficiency. And secondary adrenal insufficiency, particularly in our country, it will be very common because of the sort of indiscriminate use of steroids and other forms. So secondary adrenal insufficiency is very common in our country. So unexplained fatigue, we have to go into great detail about history, like did you take any other alternative medicines? Did you receive any injections, particularly for energy booster injections, so on and so forth? Because remember, the adrenal axis can remain suppressed for 6 months to 1 year after a course of such injections. So secondary adrenal insufficiency, very common. And fatigue and anorexia and nausea and weight loss is very common in both primary and secondary adrenal insufficiency. How do we diagnose it? You can just start off by doing a fasting or an AM cortisol. In general, an AM cortisol of more than 18 means that they do not have adrenal insufficiency. Some centers, particularly some of the UK centers, use a serum cortisol of more than 12 to exclude adrenal insufficiency. If it is less than 3.6 microgram per DL, your fasting cortisol less than 3.6, your diagnosis is confirmed. You don't need to worry. Most of the patients we see will fall in between these two. You'll get an AM cortisol of 10 or 11, and you'll have these symptoms. That is when you have to do the short synactin test. The way the short synactin test is done is like that. You check a serum cortisol at baseline, give them 250 micrograms of synactin or concentropin, and repeat serum, you give it IV or IM, and you check a serum cortisol at 30 to 60 minutes after the injection, and these are the values. So baseline value should be above 5 or 6.5. The main thing is the peak value. It should go above 18. In general, we use a value of 18, but above 15 also makes the diagnosis of adrenal insufficiency unlikely. If you have a value of around 14 or 15 as the peak value after your injection, look at the quantum of rise, increment over baseline. So let's say you started off with a baseline of 5 and you've gone up to 14 or 15, that is a good rise. They do not have adrenal insufficiency. So use all these 3 parameters to determine if maybe their adrenal gland is compromised. A couple of things to remember when you're doing a stimulation test. HRT and oral contraceptive pills will increase the total serum cortisol. So you'll have a falsely negative result. So they'll have high serum cortisol values. So ideally, they should be off these medications at least 2 to 3 months before you do the test. Prednisolone and hydrocortisone cross-react with the cortisol assays, so they need to be stopped at least 1 to 2 days before the test. Dexamethasone will not cross-react. You can switch them over. If there is a high index of suspicion you do not know, you can switch them over to dexamethasone and then do the test. There is this concept of adrenal fatigue, not really caught on in our country so far, which is a good thing. And you can see that these are the sort of, they go through it, they're saying that people, the basic concept is because of stress, the stress of the modern day that we are living in, your adrenal glands are pumping out too much of cortisol, and then it reaches a stage where the adrenal gland is tired and it cannot make any more. That entity is not accepted by mainstream medical science. It does not exist. It cannot exist like that. The treatment for it, you can see, I don't know if it is projecting clearly, the treatment for it is basically what we would anyway advise our patients. Get a good night's sleep, avoid excessive caffeine, make sure you go to sleep, whatever, at the proper time, don't expose yourself to light at night, eat healthy. So this is if anybody comes and says, because I see sometimes, even in around Chennai itself, some alternative medicine practitioners giving a diagnosis of adrenal fatigue, they should not be put on steroids. This entity does not exist. Hypopituitarism, this is the final diagnosis. They may present only with fatigue. Quite often we pick up hypopituitarism after Sheehan syndrome, due to Sheehan syndrome in women in our country. After childbirth, there is a progressive decline in these women's functional status. However, they just stay at home and, it is just taken for normal that because of they're looking after their house, they're busy in the kitchen, they're looking after their children, they just become progressively more lethargic and tired, they never come out, the diagnosis is quite often delayed. We've had people come to us with hyponatremia and convulsions, we've had people come to us with different types of presentation of Sheehan's. A clinical clue is early menopause. The diagnosis needs a high index of suspicion, so somebody you see with extreme fatigue in whom you do not have not found any other cause but has an early menopause, do all their pituitary profiling. They will have obviously a low or a low normal TSH, low free T4, free T3, sodium will be low, cortisol will be low. IGF and growth hormone levels anyway fall with age, so we cannot use it to make a diagnosis of hypopituitarism. In the menopausal women, so say someone who is after the age of 50 or 55 should normally have a high LH-FSH. In these people, the LH-FSH will be normal, inappropriately normal. So this is something important to keep in mind. Men in general, like I said, tend to have a drop in their LH-FSH and testosterone with age because of the male menopause. So it's more difficult to make this diagnosis in men. But again, high index of suspicion. If all of the hormone levels are lower limit of normal, you cannot find any other cause. Think about evaluating them further. Consider doing maybe a more testing or at least repeat the test in these people. Keep them under observation. So to summarize, fatigue is a common symptom in several endocrine diseases or their treatment. Remember to think about diabetes, medications, blood sugar fluctuations, B12 deficiency, obstructive sleep apnea, thyroid, apathetic hyperthyroidism, primary hyperparathyroidism, secondary adrenal insufficiency, male hypogonadism, and hypopituitarism, particularly Sheehan's in females. We need a very high index of suspicion, but perform the appropriate tests in the proper manner. Kumravale spoke very well about this in that first session. We need to take into account when it was done, how it was done, other medications that can affect the results. So proper interpretation of lab reports is what is essential in confirming the diagnosis. Thank you.
Thank you very much, Dr. Jayashree. As usual, you made a difficult topic simple.
Thank you, sir.
I'm sure there'll be a lot of questions. One not too sensible question I'm going to ask you. Nothing here, fatigue, what do you do?
Nothing here, sorry?
Nothing, it doesn't work out into any of your biochemical parameters. Unexplained fatigue.
So not an endocrine cause. Apart from I think the general practitioners in the audience will have more ideas. Sorry, what is it, sir? Reassurance. Thank you.
That's mental fatigue.
Yeah, absolutely. No, very important. Very important, sir. So the first one is a 45-year-old female, hypothyroid for the past 10 years on Eltroxin 200. Son of this patient is an 18-year-old boy, routinely diagnosed hypothyroid for 3 years on Eltroxin 200. TSH of both patients on review was more than 200. How to go about for both patients? I think I'll ask Muthu to answer this. I don't know, your favorite high TSH in spite of levothyroxine. Yeah. Come. And also your antibodies, you have one whole differential.
Yeah. I think the most commonest thing here would be to exclude compliance issues with the patient. But then if the patient is already has got the problem, TSH you mean, high TSH. Then we think about analytical problems like interference with antibodies. So as Dr. Kumravale said, heterophil antibodies are common animal antibodies which can also happen in this condition, which can cause the patient's TSH to go up. Here probably, generally when people are on 200 micrograms of thyroxine, we don't expect the TSH to be so high. I think mostly it's a common issue where both mother and family is. Thyroid hormone resistance is a rare condition. It can happen, but we need the other parameters to discuss that. TSH alone in this condition would be misleading. So if you've got other parameters which are showing that very high free T4 levels, then probably we can also think about thyroid hormone resistance. But generally the TSH there would not be very high as such. They'll be around, if it is thyroid hormone resistance, it will be around 10, 20 or 40. per se and not greater than 100. So this is probably more as a compliance issue or a lab analytical error due to an antibody interference. So that's.
So the couple of other things that I wanted to add, other common things are they taking the tablet in the proper manner? Where are they keeping the tablets at home? Because remember, the thyroid hormone tablet is very sensitive to heat and light. Particularly women tend to keep their tablets sometimes in the kitchen, close to the gas. So where are they keeping the tablet? That's another thing. And for some people, certain brands seem to work better than other brands. So for some people, when you switch brands, it seems to work very well. So some of these other things you need to keep in mind also. Is hypogonadism similar to atherosclerotic penile vasculature causing an ED attack? I'm assuming it's erectile dysfunction. It would be different. It would be different. This is not the type of erectile dysfunction that you would see in people with diabetes. This is happening because of lack of testosterone. In this, the drive itself will be less. Their sexual desire, their drive itself is less.
Thank you, Dr. Jayashree. I think all the speakers did a commendable job and require a warm round of applause.
Thank you, sir.
Dr. Krishna, congratulations. You have made us close on time. I think time to the dot. Thank you so much. We've all had a wonderful time and on dot. Can we close the session?